Okay, so welcome to, to this webinar. And my name is Tina Garder. I'm a trauma surgeon running the trauma service at Oslo University Hospital, and I'm moderating on the AAST side of the webinar. And I'm going to present or to introduce the presenter and the panelists for the first case. And our presenter is Professor Steve Moeng, and he is professor of surgery and also the academic head of trauma at the trauma unit at what's it called now? The Johannesburg General Hospital, or the University of Witwatersrand in Johannesburg in South Africa. And these panelists are going to be Kate Hancorn, who is a trauma and colorectal surgeon at Royal London Hospital in the UK, and also Colonel Jennifer Gurney, who is going to join us very soon from the US Army. So Steve, please share your screen and start discussing with us.
Thank you very much for the privilege, and I just want to appreciate everybody. I think we will start shortly. Just let me know when it's showing nicely, and then we can continue for the... Is it sharing?
Yes, it's sharing.
Okay, thank you. All right, so what we'll do, we'll have at least one case to discuss, and depending on the time and the moderators, we'll see whether there is another case that we can take forth and see your opinions and your thought around it. First case that we are presenting is a young man. He's been transferred to us, and we call it case one or patient one, transferred to us from another facility that's about 102 miles or 180 kilometers away. So definitely that's a kind of a patient that you will be transferring by air. Came in through to us following a severe motor vehicle collision with a one P4 at the scene. He was a passenger, and the scans were done at the original facility, and we had to work with some of the outcomes. But at some stage later on, there were some of the x-rays that we needed to do. Long and short, he had a concussion. He had a fractured foot, he had a fractured scapula, and he was also tender on the abdominal wall. And we reevaluated him on arrival. There was a small hemothorax on the left with no significant fractures of the ribs. And the other injuries from the foot as well as the scapula were as they were described. And the scapular fracture was on the left side, which was on the same side with the hemothorax. We obviously came in with the intercostal drain. We just resecured it to make sure that it works. We saw the wound that was on the left side, again, just above the iliac crest. And you could see that it was an associated hernia underneath. One of the other issues that they presented with, or he presented with, was a very stable C2 fracture that was already in a Miami J collar, but with normal neurology as well as a minor fracture of the nose. As you can see from this case, we usually would do what we'd call the lordoxy, and the x-ray. As you can see, there are some changes on the left side of the chest. And if you look on the right, this was a later one, the CT scanner that had been done. I've not been able to share it here, was otherwise not remarkable on the right side. And we were happy to look after the patient and manage him moving forward. For the purpose of the discussions today, I just want to continue from the chest point of view. So day 2, there wasn't anything major requiring a little bit of oxygen in keeping with the hemothorax, follow-up x-rays as well, nothing new, but coping and awake, and the concussion features almost have settled. And that continued as well on day 3. Except that on day 4, we noticed that he was requiring a little bit more of oxygen, and there was a decrease in air entry as well as associated slight confusion. Certainly, the ICU management was being continued at this stage, and I'm not so sure if anybody has any thoughts at this stage, because at what we looked at, we checked on the left chest to see whether there was anything new. The intercostal drain was settling, but we did notice that there was some decreased air entry on the patient's opposite side, which was the right side. Abdomen was fine, but maybe I will pause at this if there are any comments before we move on and I unveil what has happened to the rest of the patient moving forward. Tina, back to you.
Just for the first, there was one question in the chat before we ask Kate for comments. Was there a chest tube on both sides?
The chest tube was only on the left side. The right side was okay, but we'll come back to that a little bit later. Yeah.
Okay,
and
so
the CT scan, only small hemothorax on the left side, no hemothorax on the right chest.
so before one more thing. So I think Jennifer has also, the other panelist has also joined, but I think you need to let her open her audio and video, Kevin, if possible.
I did. I made her the co-host. She just needs
Okay.
to accept it.
Okay.
Yeah.
Okay.
Good.
So I don't know
So-
whether there are
so
any comments there.
Can we, any other comments from, so can we ask Kate, what are your thoughts?
So thank you. I would like to, as Steve's mentioned, just talking about the drain. So the things I would be looking at is just reviewing the drain position, making sure the holes are in the chest on the left, seeing whether it was bubbling, any suggestion of an air leak or anything on the left, or is it the right side of the chest that we're concerned about in terms of the ventilatory problems? So I'd want to make sure that I'd excluded anything obvious on the left, and then examine the right and get some up-to-date imaging if needed.
I think agreeing as well with what you're saying, we really had to look back at the patient because so far he was okay. We looked for septic markers. We checked whether his hemoglobin was dropping. We obviously reassessed him from head to toe again. And very, very interesting, we picked up that there was an increased decreaser entry or a worsening decreaser entry on the right chest, which is opposite from what the x-rays have shown, which was also opposite from the CT scanner that was done immediately after arrival. I don't know whether there's any other information that you require over and above what has been written here. The CRP not so markedly raised. The procalcitonin, as you can see, it's just 1.3, which is not too significantly elevated from what we were looking at. And obviously the surprise was what was happening on the right side. Any other questions or comments before we
So
move
I'd
on?
want a blood gas, Steve, if that was possible, just to have a look at that. And then I just want to be clear that we're completely happy clinically with the abdomen. There's nothing that we're worried about. Bear in mind, this was a blunt. He hasn't actually got some blunt shearing injury, which is presenting with a collection or something late with ischemic bowel or anything. So clinically, I just want to ensure that his abdomen is unremarkable.
Okay, thank you very much. I don't have the guesses for you, but certainly part of our workup, as you can see, was to do a follow-up scanner. And if you look at this in terms of the abdomen scanner, you still see the abdominal defect that is much more lower down around the iliac area on the lumbar side. You can see it on another scanner. And as you are aware, as this was in keeping with the right decreaser entry, you could see that there is an effusion on the right chest without, again, second scanner, without any evidence of fractures on that right side. All the other issues, scapula was a left, initial hemothorax was a left, and now suddenly, or not suddenly, but over the past few days, he seems to be accumulating an effusion on that. Abdomen is soft, the hernia has not complicated, there is no delayed features of either missed abdominal injuries, and we have this large effusion on the left side.
So the thoughts going through my mind is whether this is a reactive effusion, or whether this is delayed hemothorax. So again, whether we're sure that there's anything in the belly. I'd want to see the reformats to make sure there was no evidence of a diaphragm hernia or anything there, just to make sure that the diaphragm was intact on that side.
Thank you very much. And indeed, that was done. We looked at it, but we also decided to insert an intercostal drain for him. You are correct. The oxygenation level had gone down a little bit, as you have said, but it was very, very interesting that when we put in a drain, there was a discoloration to the drain, not as what we've seen usually, but you could see that this was not the typical type of a delayed hemothorax. It was not red. It's not showing very well. It had some sort of a color that was almost in keeping with the picture that is what we usually see with this patient on the picture that you can see on your right, compared to the one that is initially over that area. I'm not so sure whether there is anything else or whether this adds any value, but certainly there wasn't any other sepsis. Abdomen was fine. This effusion was not a reactive effusion, and certainly you worry about pancreas and all of those other issues in the abdomen, and none of those could be confirmed on a follow-up scanner a couple of days down the line. Patient is eating very well, he's comfortable, he's just complaining of chest deterioration.
So that, Steve, looks a bit like tile to me. So I'd want to send it off for triglycerides and chylomicrons just to see and whether there's anything, and make sure I hadn't missed a penetrating injury somewhere to the chest or the neck that had been missed initially, and ensure that we've rechecked everything.
I agree 100% with you. We then noted that that was chyle. We sent it off. The triglycerides were very, very elevated. I haven't included them here on the results. And obviously, with the concern that we were dealing with chyle, it was very interesting. There was no trauma on that side. There was no disturbance of the fractures or of the ribs. There was no evidence of tearing of any of the posterior segments. The diaphragm was perfect. And as I have already said, other than the small abdominal hernias, there wasn't any other clue in the abdomen that could have made us suspect that there would be this complication on the right side. And again, most of the cases we've seen would be with either those histories that I've given, or will be the penetrating injuries, which would have either damaged it or around the neck on the left side. But this patient had none of those. They were just clear blunt trauma, no chest wall disruption. And lo and behold, a very unexpected finding of a reason why he had a delayed collection in his chest. And in this case, it was a patient that had developed a chyle on that side. I don't know whether there are any other suggestions on the way forward. Just leaving it to you before I tell you what we did for this patient as a simple, straightforward case in management.
So maybe we should ask if Jennifer has also joined, if it's, do you get the beginning of the case?
I didn't get the beginning of the case, but it sounds like a mystery why there'd be something that looked like a thoracic duct injury on the right side without penetrating trauma. I didn't get the mechanism of injury, but you know, MVC, okay.
MVC, blunt trauma, P4, 1P4 at the scene.
Yeah, I mean, I would, everything that you said, look for triglycerides, start treating low-fat diet, but really understanding why he has something that looks like a thoracic duct leak if it's not coming from any type of abdominal injury and transdiaphragmatic. So it's a bit of a mystery.
Mike, can I come up with one comment, Steve?
Yes.
That hernia seemed to be a little bit, it's a belt injury, probably. And it's relatively high up, so it could be almost at the lower part of the diaphragm on the lateral side. So there could be some kind of communication there, and that could have disrupted also the duct and with the leak coming up into the chest, without it affecting much the abdomen. It's possible in that sort of transition area.
Very interesting, because you're saying that, because from our point of view, most of the cases we've seen would have been much more closer to the paravertebral or spinal area, and they would be a lot higher than that. This one was way below the liver, and the bigger wound was lower down on the left side, with the hernia on the left side more than the one that you're looking at. And you are correct, it was a seat belt just above that iliac area and a little bit round about the area of L3 region, which is what you were commenting about. Any suggestions on management of this patient?
Dr. Rizzoli is another one of our panelists. Dr. Rizzoli?
Yep.
Well, again, fascinating case. I would initially, with the diagnosis of thoracic duct injury, even though we still don't have it precisely, I would start managing medically initially, at least. So, and I think that you did it right. You put him on TPN plus his diet, right, and some other statin. Yeah.
Yeah, and we did it in a stepwise manner. Obviously, it was a larger collection and a larger drainage, but certainly there was diet manipulation so that we can at least reduce the number and the fat types and select what was appropriate for him. He didn't settle immediately, and we started him on TPN. And this is one of our rare cases where we ended up with somatostatin, and I'll allow colleagues to talk about their thoughts around it. Of most of our thoracic duct injuries, we've been able to manage them with the adjustment of their diet as well as maybe TPN. but this one we needed to go on to somatostatin. We dealt with fluid and electrolytes abnormalities, especially the sodium, and he continued to improve in hospital. And as you can see, he settled completely with conservative management. It took us a little bit longer than what I would have accepted in general. In the case that this patient, he started to eat in between while we were not watching him. So it was difficult to get compliance for him, but he settled very well. I haven't got your follow-up CT scanners for him, but he settled completely with the clearing of the chest, and he did well, and he was ultimately put on full diet and discharged out of hospital in an appropriate condition. So for us, it was a very unusual case of thoracic duct in blunt trauma. I take what Tina has said relating to the injury side, but it was not the usual site that we've seen them. There was no disruption, no fracture of the ribs posteriorly in terms of the chest side, and there was no fluid or collection inside the abdomen. All of this was in the chest, and the issue was that we took a little bit longer, but we were able to manage him conservatively. And maybe at this stage, I will just pause so that I can hear other comments around somatostatin and how long other colleagues are comfortable to manage it conservatively.
I will take just one question from the chat. Can you do cannulation of food to see the thoracic duct? Is a question from Kasim.
Can you cannulate?
Can you do cannulation of food to see the thoracic duct? I'm not actually really sure what you mean about this.
For some of us, if we are taking it to theater to operate and it had failed conservative management, we might feed them a high-fat diet in terms of either a cream or one of those double creams just before you go to theater. For us, it makes it very easy to detect it. Otherwise, you might have required to investigate it with other methods. I'll hear what other panelists say, but that's the only thing. And then you can see the duct and you can double ligate it. Most of our cases are penetrating trauma, and you'll find it around the step on the supraclavicular area around the left side of the chest. That's where most of our thoracic duct injuries have presented in a South African conditions. Yeah.
So I think we should just ask the panelists about their thoughts around somatostatin, because I mean there is maybe not very clear evidence. So Kate or Jennifer, or one after the other.
So I think the key with this is it's very unusual in a blunt injury. Obviously, with a penetrating injury in my hands, we will potentially go back in and have a look to ligate the duct early. I think the difference with this is we're not entirely sure where it's coming from. So definitely I'd advocate for conservative management. And in my hands, I've dealt with these cases at up to 6 weeks TPN, but I think patient compliance is an issue. I've not used somatostatin routinely for a trial leak. So I would let anyone else comment who's got experience of that.
For thoracic duct, not as much, for pancreatic leaks, and the evidence is, plus minus. I feel like most people try it because, you don't really have many other options if there's no surgical options. The thing about this case that's curious, and it sounds like he developed this in the hospital and didn't come in with a fusion on that side, but you almost wonder if something else is going on, malignancy or like something weird that's concurrent. There's a comment in the chat about amoebiosis or some type of infectious disease, because it does just seem a little bit strange with this mechanism of injury that there'd be a thoracic duct leak. So I do think that, further evaluation to see if there's something other than trauma that could be causing this. In terms of somatostatin, I mean, the evidence isn't good, but why wouldn't you try it? There are some downsides to it, but certainly no more of a downside than being on TPN for that long. And if you can, if you don't know where it's coming from, if you could do some imaging study, like a lymphangiogram or something to see where this is, then might be able to then target some type of surgical intervention. But the whole thing is kind of weird if you don't really understand the mechanism of why the thoracic duct is leaking in the first place.
Just one comment on somatostatin. I think, it's relatively costly, and that means, if you are going to try it, then probably give it a few days, and if it doesn't really change the amount, the amount leaking, that's something that should be abandoned, basically, from the little evidence there is. There's another question in the chat. How will you manage the right abdominal traumatic hernia? Steve,
Yeah.
maybe you want to.
So on this case, what we had decided was that we let him settle from the acute issues and then we bring him back for laparoscopic. So first CT scanner, see how he is, and then we will do a laparoscopic approach. In terms of the diaphragm, sorry, I'm talking about the abdominal wall hernia. In terms of the diaphragmatic hernia, most of us for their diaphragm, we will only interfere if we are in theater or if there is a direct communication like bile leaking into the right chest. Otherwise, the majority of the right diaphragms do settle on their own. The last indication that we've used for operating on the right diaphragm would be where we have a significant displacement of the liver into the chest cavity, in which case, obviously, you are dealing with a very large defect on that side. But for penetrating trauma, most of the right-sided diaphragms are grade 2, they are small, and you only do and repair them if you are in theater doing other things or if they complicate in terms of leaks into the chest cavity. The liver tends to buttress that area very well.
Anyone has additional comments to that?
I'll just add on somewhat. Again, I think considering the cost, the availability, and the few side effects that you can have, I say, why not try it? Right? That's more or less with the evidence that exists today. Why not try it and see if it works? Great idea.
Just one additional comment on the hernias. I think what we end up doing in these kind of hernias is that if you have another reason to get into the abdomen, then you will repair it during the initial treatment. And if you don't, then you can wait and they can be repaired, like you said, Steve, later on. Either laparoscopically, or if you need to use bone anchors because it's on the iliac crest, then if you use bone anchors, you could probably do it open with an incision just on the above the crest and go straight there, and then have a mesh inserted between, so in the TAR plane, extraperitoneally, in addition to pulling down the muscles again to the crest.
And sometimes it might be tricky to tag if you're using a hernia, to tag it nicely in that area. It's not as easily as said. So sometimes it can be challenging in that iliac blade to tag the lower part of the mesh.
Yeah, exactly. So we are now 24 minutes past. Is your other case? Do you have? Is there any other burning comments for this case?
We've heard that Dr. Vega is not going to be able to present, but his resident might be able to present a smaller case. So, Dr. Moeng, maybe you're good to present your second case. No need to hurry too much. How about that, Tina?
No.
Yes. So, Jose, do you want? So Steve can do that first.
Yeah, that's fine. Okay, then if we go to the second case, if you allow me. This is a car versus bus incident, prolonged entrapment, and ultimately arrived about 1 hour, 45 minutes. He was a front seat passenger. He was wearing a seatbelt, and all they didn't put an A-line, they didn't put any airway management. He was reasonably awake, and they were comfortable with the sets. I think most people might worry with that kind of a prolonged period, but that's how we received him on arrival. And you notice that when he was breathing like somebody that has got a hemothorax, like slightly pushing a little bit around the airway. But air entry was good bilaterally, so it didn't make sense. When you've had somebody with a bit of a hemothorax on the side, you know exactly what I'm talking about. But I need to emphasize there was no flail and there were no fractures of either the chest wall, no rib fractures, no sternal fractures. He had wounds on the face, including the mandible that was also fractured. He had a Glasgow Coma scale of about 14 out of 15 pupils were equal. He had an associated fracture of the femur on the left side as well as the forearm. And other than the degloving wounds on the face and the foreheads, he was saturating at about 85%, which obviously on arrival was making us uncomfortable. And we decided with the primary survey, like everybody else, except that it was difficult to fit the ET tube past the cords. So he's one of our rare cases where we ended up doing the emergency cricoid using the tracheostomy set. It's not usually these days with all of the adjuncts that are available, you can work around him. But with this patient, we decided ultimately to go for a surgical airway. You're looking at his blood pressure, 104/44, a little bit of a concern about that, and I'm sure you'll pick it up later. And he's got an FI2 of 1. We've applied the skin traction for the fracture femur. We've put up a POP slab as you would for these kind of cases. We have put up the airway, and I've explained the surgical airway here. Plus, we've put him on a ventilator. But just look very closely at the pattern of what you are looking at that chest X-ray. That's a chest X-ray immediately after arrival of the patient. Maybe I will stop here a little bit before we unfold the rest of this patient's management. Any comments around it? Glasgow was 14, and this is the pattern of changes that we are seeing on his chest X-ray, and it's going to develop even more from here onwards. Any thoughts at the moment, colleagues?
Can I challenge Jennifer?
Sure, yeah.
Yes, I know.
Well, I want to make one comment about not getting the pre-hospital airway. You know, in this patient, if he wasn't volume resuscitated or if he needed transfusion, it might have been a good thing, because positive pressure ventilation for an hour and 45 minutes of pre-hospital transport, if, you know, there wasn't any blood available, if he needs, you know, that type of resuscitation, might have been challenging. So he was maintaining his airway. His stats weren't ideal when he got there, but also, you know, obviously with the mandible fracture would have been tough. So it looks like on the chest X-ray that there's more perihilar kind of patchy opacities. On this, I can't see on my computer any evidence of pneumothorax. There's no subcutaneous air. I don't even see any rib fractures that I can't see. Am I missing them?
No, you're absolutely correct, Jennifer. And I like the way that you've seen the distribution, because that was an issue. And your thoughts around that distribution, if we're looking at it, what sort of thoughts? There's no hemo, there's no pneumo, there were no fracture ribs.
I want to see what his FAST look like also, especially the pericardial windows, and if he had a sternal fracture, something that would suggest any like mediastinal trauma. And you know, but there's no, you said he was acting clinically like he had a hemothorax, but there's no hemothorax on that, that's for sure. But there is definitely some perihilar and mediastinal opacities that are concerning for some type of potential crush injury or maybe some type of trauma to the mediastinum. I don't know with our, I don't know what the BUN and creatinine were with those units. I was trying to figure out. First, I thought a BUN or creatinine of 159. I've never seen anything that high, but we use different units. So
it's slightly elevated.
Okay.
So. Thanks very much, Jennifer. I forgot to prepare for the international group. But it's slightly elevated. It's not catastrophic. It's in keeping with muscle and soft tissue injuries. And you are correct, that pattern was worrying for us. And actually, we were wondering, because he was pushing against pressure, whether it's an early version of negative pressure pulmonary edema. But obviously, if you put somebody on positive pressure, it needs to be better. We did the usual secondary survey, as you know, plus minus the scanners. And to confirm to you, there was no evidence of, okay, that is it. There was no evidence of a sternal or chest wall or any bruises around the chest wall. And it was a little bit of a problem with the distribution of what we're looking for. The aorta was fine, the abdomen was okay, but it was a thorough pen scan. You could see the changes a little bit more than what you appreciated on the scanner. And the CT brain, as you could see, there were some smaller traumatic subarachnoid. And if I repeat the CT scanner, you can see that there was as well a little bit of bleeding into the ventricles in that region. So I will continue with that. Just wanted to make you aware that it was a full pen scan according to the standard of ATLS management, but just concentrate on the head, and then I'm going to pause a little bit later after giving you a bit of more stories so that I can hear the thoughts. But please remember, there is no chest wall injury of any sort under the circumstances. Except that while he's in ICU, within 2 hours of admission to ICU,
Steve, can I just make one comment from the chest, from the chat? There was a comment from the chat saying that in my institution, we always take the patient to OR for intubation while the OR surgeon is on standby. Do you want to say something about reality?
Yeah, but now we work very closely with the emergency department. Most of our airway, we manage them in our ED. This patient with the CES that we're dropping, we didn't feel like compromising him any further after the delay. We sorted out the airway management in our ED. We are set up to do that. So it might be different from other units, but we have difficult airway trolleys and availability to deal with them within our ED environment. Okay, so coming back to the patient.
Dr. Moeng, if I may, so the initial X-ray is quite impressive, right? Because again, the lack of fractures or anything directly to the chest, but this distribution, I would say, it's almost like a butterfly distribution, right? So it's it reminds me of a blast type of injuries, right? That sometimes we see. Again, we see many blast cases, but that's the type of distribution. Looks like almost, and now it's turning into ARDS as I see here, X-ray.
Yeah, so this is, can I remind you, this is within 2 hours of arriving in ICU with worsening ventilation. So throughout the time you are seeing him deteriorating, and if it was negative pressure, by now the lungs would have been much better for those that have experienced that. He's starting to drop his blood pressure. His repeat hemoglobin levels are remaining okay. Base excesses and lactate are not. And I want you to realize there was not a fluid overload here. We were not dealing with a fluid overload at all. I want to show you something a little bit. That's a slightly, and you can see that anybody, even if I haven't worked in ICU, that patient has got froth and obvious pulmonary edema. So even if you are not so sure, it doesn't make sense. May I highlight that at this stage, the troponin results come back. We were not aware of them earlier on. They've just come back now because of a delay. It was not the ISTAT. The pro-BNP was 142, which is not too bad. But you are aware he's retaining CO2, he's worsening, requiring more inotropes, his blood pressure is dropping, there's no evidence of bleeding. You repeat the ultrasound in the chest as well as the abdomen, there's nothing else other than the worsening lungs that you have seen. We even change him from one version of a ventilator to another. May I stop here at the moment and allow some thoughts from the team, please, just to put it together for us from all the evidence we've had up to so far. Thank you.
Steve, any evidence that he aspirated, like a massive aspiration?
No, other than maybe that scanner that sometimes you don't know whether you are looking at it, but there wasn't any history that he had vomited, nothing evidence of significant aspiration. However, there was an insult to the lung, and that is what the concern is. And you are correct. You start thinking about aspirations, you start thinking about contusions, etc., etc. But certainly amount of pulmonary edema was not in keeping with the fluid. This is not an overloaded case. He's not in acute failure. But you can see that in 2 hours of maintenance fluids, he's already gone into that.
Can we just ask you, was this guy healthy from before? Was there anything else in his history?
We were not so sure at that state. However, the family confirmed that he was well. He was going to work as well. So he was at least well enough to even go working when this incident happened.
There are several comments in the chat now about what about ECG, echocardiography, tricuspid valve failure. What's happening around his heart?
Yeah, certainly with those troponins, you need to ask a little bit harder on the heart. And I'm not so sure if there are anything, but let me show you more or less where we are. So there is an echo that was done on the patient, is going slowly. And we are looking at the mitral valve. And at this stage, you can see that there is a problem relating to the mitral valve. So his problem was not right-sided, it was left-sided problem, which was explaining very well why we were in trouble with the pulmonary edema. And if you look on the other side, you can see it. And when we do and we are running this patient, you can see that there is a regurgitation or incompetence of that mitral valve over that side. So the questions that we're asking about what is happening to him were certainly in keeping with the change that we were seeing at this stage on following up. And you can see that the blood pressure was variable. We were also starting to turn from sinus rhythm, which he has been in from the beginning, and starting to develop some of the extraventricular, and the rhythm was all over the place with associated issues in terms of the cardiac output. And as I've said, the pulmonary edema that was not worsened by any other issues. We were not convinced about aspirations. We were not convinced about major contusion in the absence of fracture ribs, etc. But certainly this patient was worsening with a left ventricular failure that you can see relating to a mitral valve prolapse that had taken place in this case. Now, we've all dealt with blunt cardiac injuries. I'll hear other specialists here, but it was one of the first one where we've never even had even the sternum or fracture ribs. There was nothing on the chest wall. That is what you keep together when you are dealing with these patients with blunt cardiac injury. And yet he managed to rupture his mitral valve and was rapidly deteriorating into acute cardiac failure from the decompression of that mitral valve. I'm going to stop there just to ask for comments, please.
Can we allow one comment from one of the audience, Albert Varon? Is it possible?
Thank you. Yeah, you know, as you presented the cases, when I see a surgical airway and frothy sputum, the first thing I think is post-obstructive pulmonary edema. It's the first thing that comes into my mind, correct? That sputum is classic of somebody who could have obstructed the airway, and you see it. But as you said, after 2 hours with a little bit of CPAP, it should have gone away. Now, I think right now you just put the entire case together of a patient with blunt cardiac injury. If you look at that monitor, the patient has a bundle branch block. So think about it. This is a sternal injury. You have arrhythmias, you have a decrease in cardiac output, and you documented now mitral valve injury. So this is blunt cardiac injury, basically, and resulting in cardiac failure.
Thanks for the comments, except that there was no sternal fracture, there was no bruise around the chest, there was nothing else on the outside of the chest, even on a CT scanner, that would have really made us from the beginning put this nicely and easily together. So it raised a number of issues. I'm just going to conclude in the interest of time. It raised a number of issues. We needed to put him on AV, not VV ECMO, for obvious reason, cardiac support as well as respiratory. We dealt with issues around heparin and the head injury that he had, and the issue around timing, and brought all of those debates together. But the patient ultimately ended up with a valve replacement, as you can see in this X-ray. You can see that we were over the pulmonary edema. We were able to win him from ECMO, and he was prepared to go to rehab for further management. So the main reason why I presented this, a very unusual blunt cardiac injury, no chest features that were obvious for us that would be the typical association, and with a rapid cardiac failure, that then the deterioration. I think I'll leave it there in the interest of time. Thank you very much, Chair, for the opportunity.
That was amazing. Thank you so much, Steve. And I think in the interest of time again, I think we should leave to Martha to take over coordinating the next case. And everybody stay on for possibility of commenting the next case. Thank you.
Good morning, everybody. Thank you for this amazing presentation. Today, we are going to have Dr. Luis Zamora. He's a resident from Mexico for Dr. Felipe Vega at Hospital Ángeles Lomas de Mexico City, Mexico. He's going to present a case, and our commenters or panelists are going to be Dr. Sandro Rizzoli, and Dr. Moeng, and we are waiting for also your comments and responses about this case. Thank you. Dr. Luisa Mora, can you please share your screen?
Thank you, Doctor, of course. Is it already? Can you see my screen?
Yes, we can see it.
Okay, perfect. Okay, well, perfect. So the case that we're going to talk about right now is about the importance of the time activation of the trauma team and the interinstitutional communication, and how this is favorable for a good prognosis in a patient with severe trauma. So the objective of this small presentation is to show, based on a clinical case, the relevance of the activation of the trauma team and how its response and interinstitutional communication between private and public institutions, especially the way we have them organized here in Mexico, are factors and can be factors that will create an advantage in the patients with major trauma and their outcomes. We all know this. The major trauma is defined as an ISS more than 16 points. So the issues that we're facing, especially us as low-income countries or mid-income countries, are that the trauma is the leading cause of death in patients in productive age. There are difficulties. We have many difficulties in the follow-up of patients among private and public institutions. And of course, we have a very important disparity in resources. We don't have enough protocols and systematization, and we don't have, unfortunately, any trauma centers here in Mexico City. So with the case, we have a 56-year-old female. She was a pedestrian. She got crushed and pressed between two cars and the school wall by a van. Once the EMT got to the place, a tourniquet is placed, the extremity is decompressed, they placed a compressive bandage, and the patient is immobilized. They transferred this patient with O2. They didn't place any IVs. They took her to the hospital with the bleeding partial controlled in a 60, maybe 80%. She loses consciousness about a block away from the hospital, and she falls into a witnessed respiratory arrest. She enters shock trauma room without a pulse, with CPR taking place, and that's when the trauma team activation takes place. So as you can see, one of the things that worked out very good in this patient is the time frame. The EMTs arrived in around 2 minutes. The patient was no more than 5 minutes in the site, and the transfer was very quick, 2-minute transfer. So the time is on our side right now. We started carrying out the protocol, CPR. Left proximal saphenodissection is performed, which is contralateral to the affected extremity, that we could do in around 30 seconds. She recovers pulse, she enters bradycardia and then tachycardia. That was around 5 minutes of reanimation. Then the blood pressure could be stabilized, even though she was at a profuse hypovolemic shock. 60-40, then 80-60, saturating at 90%, and with a heart rate of 150 beats per minute. So We had then a mangled extremity to the proximal thigh. The mangled extremity severity score was around 9. She had an arterial and venous injury to the superficial femoral nerve, femoral artery, vein, and the nerve elongation. She had in the mid femur a comminuted fracture, and she was still at a grade 4 hemorrhagic shock. During the surgery, we carried out a transfemoral amputation. We had still persistent arterial bleeding from the stump, so we were required to place a tourniquet, a pneumatic tourniquet, and we had to pack the stump. So as you can see in this picture, one of the things that we needed to do with this patient was, since she had persistent hypotension, we had to turn the operating room into some kind of hybrid operating room that we could do with a C-arm and fluoroscopy, so that we could perform a more variety of procedures in this patient. As you can see, the patient has placed the pneumatic tourniquet. It's the stump is packed, but you can see in the image that it still has some active bleeding, since the blood is all over the packing. So what we did then with the improvised hybrid surgical or operating room was we needed to perform a right leg angioembolization, because we couldn't control the bleeding only by the surgical maneuvers. She was still bleeding from the gluteal artery, the inferior gluteal artery, so we needed to perform an angioembolization. During the exploratory laparotomy, we found some small intestine contusions, a hematoma in retroperitoneum, zone 3, non-expanding, a grade 1 injury in the cecum, and a small ovarian injury where she was actively bleeding, but we could control it surgically. We then moved the patient to the ICU, where she started with respiratory distress.
Perhaps Dr. Kiodetis, you want to ask the panelists some things?
Yes, I'm sorry to interrupt, Dr. Zamora. I just want to ask about the initial management of these patients and the lack of transition, and a patient that is coming into arrest to the ER after a traumatic amputation or crash. Dr. Rizzoli, what do you think about using ACLS CPR on this type of patient?
So I'll just comment to the introduction that Dr. Luis made, Dr. Zamora made to his case. So in my opinion, when you look back at all the bad outcomes that we have in our patients, usually we tend to think that someone did something wrong. But the fact is that most of us are reasonably well trained. The problem is not the doctor that's bad, it's the system that is not prepared. So usually the errors, the problems are systemic. So I agree completely with his hypothesis that the best way to improve care is to have a good system that works. So I think that we have set up rules for blunt and penetrating cardiac injury when they have cardiac arrest. I would say that in a case like this, where you know that the problem is isolated to the extremity, and this was 2 minutes before the patient arrives to the trauma center, to the hospital, I think it's more than reasonable that the patient should be given a chance. And again, ACLS and chest compressions are indicated, in my opinion, for this case. And looks like that we're going to see that was the right choice.
Thank you, Dr. Rizzoli. Does anybody want to comment something about the resuscitation of this patient at the beginning and also the way to control the bleeding in a transition zone?
What did you ask us?
I think our other panelists are Dr. Hancorn and Dr. Gurney. Did you have any thoughts on that, on those questions, or Dr. Gardner?
So can I, it was commented that there was still ongoing arterial bleeding after you had amputated the leg. I would say so that my thought was just, was there a plan to have proximal control before finalizing the amputation? So if that could have been done, maybe in the groin, maybe a little bit higher up, to get earlier control of that bleeding, that would probably be my choice before finishing the amputation.
You know, also in those wounds, it is so hard to get, you know, if the vessel's staring at you bleeding, that's easy. But usually there's so much soft tissue destruction that getting, you know, control is really challenging. So some type of proximal control, either with a, you know, direct femoral cut down or retroperitoneal control, or, you know, even, you know, lateral, you know, using a ROBOA, a distal ROBOA zone 3. The disadvantage to that is you really put the other leg at risk. So I think that's kind of a last resort if you can't get surgical, you know, control with either, you know, at the groin or through the retroperitoneum.
And you also end up doing a laparotomy anyway. So if you had started maybe that earlier, just to make sure, because it's so close to the abdominal cavity anyways, to rule out other injuries. And then there's a very simple access to the vessels there on that side, like you said, without jeopardizing the other leg.
Just for comment, there is no ROBOA in Latin America except in Colombia. So yeah, there's something that we have to take into account. And this setup as a hybrid room is some things that we need to do all sometimes, like just call our interventional radiologist into the OR to help us doing a hybrid management. It's not a formal hybrid room. And also, I don't know, Dr. Zamora, how is in your hospital, but we do not have sometimes access to blood products to transfuse. So it's kind of a not a very good environmental setting for dealing with this type of patients. So Dr. Zamora, there is a question about trying to get into the abdomen or proximal to the injury to try to control the bleeding. Can you answer about that?
Yeah. Well, addressing everything that everyone has asked so far. As you said, we don't have, unfortunately, ROBOA here at Mexico. It's supposed to be in its way with the COFEPRIS and everything. Maybe not ROBOA as the catheter, but the Cobra. But anyway, we don't have any arterial occluding catheter right now. We ended up performing a right hip disarticulation, but first we wanted to see if we could salvage the remnant stump, and that's why we decided to perform the angioembolization instead of disarticulating as a first resource. Talking about the blood products, we don't have so much trouble in our hospital. We do have access to blood products, so we don't have a big issue with that.
Yeah, can I
don't know if
it's Jennifer, if I, so ROBOA is one thing, and I think that, we've done surgery for a long time without ROBOA. I think that, it's a tool, it's not the tool, it's a tool. But with regard to blood in someone like this, I know it's really hard to get systems of care set up to have timely transfusion. But, you know, if you don't have blood, what happens on the other side of the blood-brain barrier or the blue drape between anesthesia is they're trying to manage the blood pressure and keep the blood pressure normal, and they're giving crystalloids, which is making your coagulopathy worse and making the patient more acidotic and coagulopathic. And so I just think that it's, you know, I mean, acknowledge the challenges, but, you know, if there's, really in addition to surgery, obviously, such an important life-saving intervention, not just for the time of surgery, but really to help manage their post-surgical sequelae is getting timely blood transfusion. Just one bit of experience from the military is we use blood very liberally, and we use it far forward. And one thing that we've observed is with these huge traumas, whether it's blast injury, bad amputations, high amputations, that our rate of ARDS has gone way down. And I think it's because we're using very little crystalloid in the resuscitation. But if you don't have blood as an option, they're going to end up getting crystalloid and sometimes a lot of it. And I think that puts our patients at risk. So, you know, I know it's hard, but one way that we've been able to get our blood system to work is to just really engage with the blood bankers, the donor centers, and but that understood that worldwide it's still a challenge to get timely transfusion over.
Yeah, and the absence of massive transfusion protocols that we don't have in Mexico City or in low-income countries, that's also kind of hard.
Just make one comment, and I think that's about Reboa as well. So you say that you don't have Reboa in most of South America. We do not use Reboa in Norway because all the evidence show that there is much higher mortality when in matched cohorts with Reboa in most instances, and that's because you don't have much time when you use that. And I really agree with all the comments of Jennifer Gunny on this as well. But I think not being able to have Reboa is not an excuse for not doing the so it shouldn't feel like something you're missing. Surgery is absolutely valid as an option, and like you said, with good blood products, you don't need to devitalize half the body in order to save the patient. And you don't have more than 30-40 minutes before you actually get to the patient. You push the patient into multiple organ failure with Reboa. So I think your surgical approach is absolutely valid.
Yeah, as a matter of fact, we think that Reboa is a great tool. It's a great alternative to have, but it should not be considered anything else than a bridge therapy.
Yes.
Between
short bridge,
the
very
initial
short
management and the trauma or the damage control surgery.
And if I may too, it's interesting. We have Reboa here in Qatar, like, as much as you want, but we're not finding the patient, right? Our number of Reboas is so small that it's faster to take the patient to the OR. And here we're fortunate that we have a hybrid OR, so we can very quickly have multiple teams taking care of this patient. That we don't find the use of Reboa. We can find a good use for it. And if I can,
I'm sorry to interrupt.
Yep.
Sorry to interrupt. In order to get into the time, please, it's almost 12. So can you, Dr. Zamora, can you tell us more about the case, please?
I'm sorry, I didn't hear the last part.
Can you finish the case, please, Dr. Zamora?
Oh,
it's
yeah,
almost
sure.
12.
Sure, sorry. So since the angioembolization, the patient started with an ischemic stump. She started with necrosis. So we needed to take her to the OR again. This is all the blood products that we needed to use during the reanimation or the initial resuscitation of the patient. We had to use the negative pressure wound therapy. And well, these are all the final diagnoses. And the picture is with Dr. Vega, who was the leading trauma surgeon during this case, and the patient after everything she went through. She could go home 33 days after the transfer, after the trauma took place. And 8 months later, this was the the patient. So she had a good outcome. She still has a good life quality. So everything turned out to be okay.
Thank you, so Dr. Zamora. Just to save time, just 2 more comments and we close the meeting. And thank you very much for these cases today. Dr. Rizali?
Yeah. So again, I'd say here the lesson is system, organization, protocols, extremely important. In my opinion, more important than Reboa. Second of all, blood, hold on crystalloids. And the one that I'll add is that make sure that you're monitoring coagulopathy too, right? You have to monitor. Even if all you have is INR and PTT, measure that and measure regularly as you resuscitate the case. Like a beautiful case, glad that CPR was done for this patient and that's the result. Thank you.
Thank you all for your participation. And thank you for sharing your cases and your experience. Bye.
Echoing that, thank you all for being here together with us for these great cases.
Thanks everyone.
Tina. Great to see you.
Great to see all of you.